Hello friends. In today's session, we have Professor Rohini Handa with us who will be discussing an introduction to Spondyloarthritides. Professor Handa is a senior consultant rheumatologist at Indraprastha Apollo Hospitals presently, and he was previously a professor of medicine at the All India Institute of Medical Sciences, and he is a brilliant teacher and a mentor extraordinaire.
All right. Thanks, Ashish, for the generous introduction. Good morning, friends. And at the outset, I would like to thank Professor Goyal for inviting me to join in on today's lecture on spondyloarthritides. Ashish and I were colleagues at the All India Institute of Medical Sciences many years ago. And my brief today morning is to discuss the concept of spondyloarthritides. Well, this is a listing of the common arthritides that you would encounter in clinical practice. In terms of commonality, osteoarthritis heads the list. Then you have gout, rheumatoid arthritis, and spondyloarthritides, which we are going to discuss in a little more detail. And I think this point has already been discussed, that you divide the arthritides into two broad groups, the non-inflammatory disorders and the inflammatory arthritides. The flagship disease here is osteoarthritis. And in terms of commonality, this is what you would encounter in the community in terms of frequency. In India, osteoarthritis of the knees. In the Western world, I think osteoarthritis of the hips. And then you have osteoarthritis of the hands, osteoarthritis of the spine. So you have multi-sites being affected. And you have already been told about the distinction between non-inflammatory and inflammatory joint diseases. And this distinction is crucial in clinical practice. With osteoarthritis, you have a use-related pain. The lady would say, "जब चलती हूँ तो घुटने दुखते हैं." And when she's sitting on the chair, sitting on the bed, she doesn't complain of pain. In contradistinction with the inflammatory arthritides, what you have is movement eases the stiffness and the pain. The person complains of stiffness in the morning. With use, these joints loosen up. Morning stiffness is a key feature. And then, of course, you have the acute phase reactants being elevated in the inflammatory joint diseases. Now, if you look at the inflammatory joint diseases, as you've been told, you divide them into a single joint involvement, monoarthritis. Then you have polyarticular disease or oligoarticular disease. 2, 3, or 4 joints are affected. And when you have 5 or more joints being affected, that's polyarthritis. Flagship disease here is gout. And I must tell you that gout is most often monoarticular, but it can also be oligoarticular and rarely polyarticular. Particularly in the elderly, polyarticular gout is not uncommon. When you talk about polyarticular disease, 2, 3, or 4 joints being affected, the most important entity here is the spondarthritis group or the spondyloarthritides. And when you talk about polyarticular disease, rheumatoid is the prototypic disorder in this group. Now, this is the textbook picture of ankylosing spondylitis. This posture is characteristic. You actually don't need any investigations once you encounter a situation like this. The spinal mobility is restricted, chest expansion is restricted, and the X-rays show a bamboo spine. But if this is the kind of picture that you are looking for when you talk about diagnosing angspond in the early stage, this will necessarily lead to an inordinate delay in diagnosis. Such a florid picture takes time to come up, and these days, when you have several interventions available, it's early detection which determines the outcome in most traumatic disorders, and ankylosing spondylitis or the spondyloarthritides are no exception. The lag period between symptom onset and a diagnosis of spond or spondyloarthritides on an average is 7 years. And the reason is low back pain is ubiquitous in general practice. There are two disorders which I think are very common. One is common cold and the second is low back pain. And the first task of the clinician is to differentiate inflammatory back pain from the mechanical back pains. And inflammatory back pain accounts for no more than 5 to 10% of the cases. If you look at the community, maybe less. And if you look at a hospital-based practice, about 5 to 10%, which means that should a patient come to you with back pain, the chances of an inflammatory back pain are only about 5%, no more than 10% in a tertiary level referral practice. But the importance is overlooking inflammatory back pain leads to delay in diagnosis, which translates into a bamboo spine, which is often irreversible. So this is the reason that we emphasize on early pickup, and I shall discuss that in a little while. Now, as a group, the phenotype of spondarthritides, and I use the term spondarthritides, spondyloarthritides, or the SPA or the SPA group interchangeably. The classical phenotype is age less than 40 years, male preponderance, back pain which is inflammatory in character. The person says that I go to bed all right, but I wake up towards early morning, I'm stiff all over. Some people cannot turn sides in bed. Enthesitis is a characteristic feature, and this is pain at the tendinous insertion sites. Rib pain is very characteristic. Khas nahi sakta, cheek nahi sakta. That's the kind of history that you get, and you get an alternating buttock pain. Sometimes the right buttock, sometimes the left buttock. And should you have involvement of the joints, not everybody has it, but should you have involvement of the joints in addition to spine, it is asymmetrical, oligoarticular, preferential involvement of the lower limb joints and large joints. And this is the phenotype that you need to commit to memory, just like you commit to memory that rose is a red flower, fragrant with thorns, and marigold is yellow. So this is called pattern recognition. And these patterns have to be ingrained into you, just like you know that mitral stenosis has a diastolic murmur and regurg has a systolic murmur. Much in the same way, the arthritis of this group is asymmetrical, preferentially affects the knees or the ankles, is pauciarticular, 2, 3, or 4 joints, and has a predilection for large joints. And this phenotype is remarkably different from rheumatoid arthritis. The radiologic hallmark is sacroiliitis, so it is actually a misnomer like many things in medicine. While spinal involvement is important, but it is the sacroiliac joint which is the seat of the disease, and the genetic marker that is associated is B27. And these are examples. Young male patient, you can appreciate large joint involvement of the lower limbs, appreciate the quadriceps wasting. Unfortunately, in our country, they get a label of tuberculosis. Anti-tuberculosis treatment is instituted, and few people would bother to ask about the history of back pain. In fact, the patient has had back symptoms for a while, and may actually be quite irritated when you question about the back, because he'll say, I've come to you for the knee, don't bother about my back. And this is one of the major reasons for delayed diagnosis, that one does not question the patient about back symptoms. So this is oligoarticular disease for you, large joint affected knee, asymmetrical. This knee is all right. And if you look at more examples, look at this. Ankle involvement one side, inflammatory edema of the foot, the other ankle is all right. So asymmetrical distribution, one side is affected, other side is spared. It could be two knees, one ankle, both ankles, one knee, and you have large joint involvement, lower limb involvement, and then enthesitis. And this is the classical site, the tendo Achilles. People would also complain of heel pain, rib pain, pain around the tibial tuberosity. So that's enthesitis for you. And if you look at the digits, what you get is dactylitis. Now, dactylitis is very different from the fusiform swelling that you get in rheumatoid arthritis. Fusiform swelling is plump in the middle, slender at the sides. So this is characteristic of rheumatoid arthritis. And in contrast, what you get in spondarthritis is a cylindrical swelling, and this is because of tenosynovitis. This is also called a sausage digit, and once you get this kind of a sausage digit, actually there are virtually no differentials. You think of spondyloarthritides, whether it's psoriasis, whether it is angst-Spond or reactive arthritis. Rarely you could have dactylitis with sarcoid or tuberculosis, but from a teaching learning perspective, in the setting of a joint involvement and inflammatory back pain, once you see this, your diagnosis is clinched. Now, why was I emphasizing on the phenotype, and why did I allude to the example of a marigold and a rose? Because in rheumatology, you learn to recognize patterns, and this is ingrained into you. This slide lists the pattern, the phenotype of two common inflammatory joint diseases, rheumatoid arthritis on one hand, spondyloarthritides on the other hand. This is a polyarticular disease. This is a polyarticular disease. And what you have in rheumatoid is a bilateral symmetrical inflammatory polyarthritis involving the small joints of the hands. So you have involvement of both the sides, wrist on both the sides, the fingers on both the sides. Mirror image symmetry is not required. You could have the fifth PIP on one side and the third and the second PIP on the other side. So it's bilateral, it's symmetrical, and it's a polyarticular disease involving the small joints, and one is very reluctant to diagnose rheumatoid arthritis unless the small joints of the hands are affected. And if you contrast it with the phenotype of spondarthritis, this has a predilection for large joints, is oligoarticular, is asymmetrical, and lower limbs are affected much more, and you have low back pain. In fact, rheumatoid spares the spine. The only portion of the spine which is affected in rheumatoid is the cervical spine, and then you have a duration in excess of 6 weeks, and this is primarily to differentiate it from viral arthritides, so very common in clinical practice, which are self-limited. So this is the contrasting phenotype of rheumatoid versus spondarthritis. Now, spondyloarthritides are a big group, at the center stage of which is involvement of the SI joint. The genetic marker which is associated in an overwhelming majority, but by no means in all patients, is B27. You have a substantial number of people who are B27 negative. The flagship disease is ankylosing spondylitis, but this is one polar end of the spectrum. You have other entities Psoriatic arthropathy is included. Spondyloarthropathy is related to inflammatory bowel disease, both Crohn's and ulcerative colitis. Reactive arthritis, that shall be discussed with you a little while later. And when it happens in children, age of onset below 16, the juvenile spondarthritides, which are also called enthesitis related arthritis. And then you have in nature, not everything is black, not everything is white. You have shades of gray, much in the same way. You have patients which belong to this group. You cannot slot them into angstpon. They don't have psoriasis. They don't have inflammatory bowel disease. There is no preceding trigger that you can label them reactive arthritis, nor are they children. So what do you do with this group of patients? And you call them the undifferentiated spondyloarthritides, and this nomenclature has now been replaced by non-radiographic spondarthritis, and I shall elaborate. So if you have patients where you suspect spondarthritis, they do not fulfill the criteria for being categorized as any one of these entities. The terminology employed is undifferentiated spondarthritis, and this nomenclature is now being increasingly replaced by the term of non-radiographic spondarthritis, and I shall explain. Now, historically, ankylosing spondylitis relied upon clinical criteria, back pain, inflammatory in nature, and X-ray evidence. Back in those days, 40 years ago, what was important was specificity. You had to differentiate the garden variety of back pain, the mechanical back pain from angstpon, and time was not critically important because you had hardly any active intervention to offer these patients except for physiotherapy and anti-inflammatory drugs. And there has been a paradigm shift in this. Now you have a slew of interventions. Early intervention makes a world of difference, and mind you, specificity is reciprocally related to sensitivity. So these criteria which insisted on X-ray changes were very specific, but by their very nature not sensitive. And if you were waiting for sacroiliac joint changes to appear, as you can see here, virtually they are fused. By this time, the hip has also gone, and you can appreciate the joint space narrowing here. This hip is also begin to show changes. You can see the enthesophyte here, and you can see subtle changes on the symphysis pubis. So if you wait for the textbook picture to appear, surely you will get it in due course of time, but it is like closing the stable door after the horse has bolted and you have lost the hip by that time. And this is the reason why you need to pick up early. Now, this is a father-son duo. Father has characteristic angstpon, and the son is beginning to manifest features here, and you need to pick up patients at this stage, not at this stage, because these days intervention can possibly prevent this. And this is to sensitize you to the fact that when I was a student, I was told that don't think of ankylosing spondylitis in women, and we now know differently. The male-female ratio is 2 to 3:1, and this is a lady with advanced angstpon, and this is a mother-daughter duo. This lady has had a spondyloarthritis for years, and her daughter, as you can see, the posture is erect, but she started developing symptoms, and we need to pick her up at this stage, which is why we have moved away from insistence on radiologic changes on plain X-rays, and which is where MRI comes into the picture. MRI helps pick up bone marrow edema, and this bone marrow edema is a forerunner or a precursor of structural changes that you get on the X-rays. the CT is good at picking up bone, but it doesn't show up bone marrow edema. And the reason why this has been a game changer. So in a patient with back symptoms who's B27 positive, normal X-rays, you employ MRI, or even when you have B27 negative, but your index of suspicion is high, and if should you pick up bone marrow edema, which is unequivocal around the sacroiliac joints, you can label these patients as non-radiographic spondarthritis. And in this context, non-radiographic talks about plain X-rays. So non-radiographic is a term used when you have normal plain X-rays, abnormal MRIs, and this group used to be categorized as undifferentiated spondarthritis. And now with the widespread usage of MRI, most of these patients of undifferentiated spondarthritis, which we had the gut feeling that they belong to the same group, we had no substantiation. Now we can prove using a MRI that they are indeed part of this group. So this is the nomenclature change which has transitioned from the terminology of undifferentiated spondyloarthritis to non-radiographic, which is the preferred term. So what does that leave us with? It leaves us with a continuum. On one side, you have the bamboo spine, syndesmophytes. This is the classical thing that we were taught 30, 40 years ago, that angstpond is bamboo spine. Not everybody develops bamboo spine. Some people have only sacroiliac joint involvement. This is called radiographic disease, and radiographic SPA is nothing else but angstpond. And you have a non-radiographic stage which is called undifferentiated SPA, and as you can appreciate, this is a 10-year-old publication. Those days we were beginning to call it pre-radiographic, but the preferred terminology now is non-radiographic because progression is not inevitable. Some people will stay undifferentiated. That is why this pre-word has been dropped, and now people talk of non-radiographic. So in terms of the literature today, you have a spectrum. You have spinal changes, sacroiliitis, plain X-rays are utilized, and when you have plain X-rays showing characteristic changes, you call it radiographic SPA, which is indistinguishable from angstpond. When you have symptoms and B27, X-rays are normal, MRI is positive, you call it non-radiographic, and this is what we used to call 15 years ago as undifferentiated spondarthritis. And then of course there is one tiny subset where even MR may be normal, X-rays may be normal, but B27 is positive, and you have a constellation of other features which permit diagnosis even in the absence of radiographic changes. But I will not bother you with the nitty-gritty of that subset. And this is the reason why you need to pick up disease early, because ankylosing spondylitis in its full fury, the hip goes. And a young male patient who's often the breadwinner of the family, for that matter a woman, you find that usually hip destruction is a major determinant of quality of life, and things like marriage, things like having sexual relationship, particularly in a woman with a hip involvement, these could have deleterious consequences on quality of life. I would like to end at this stage by saying, don't search only for angstpond as the disease, a representative disease of spondyloarthritis. Remember, you have other entities: psoriatic, enteropathic, reactive. Children can get it, even the elderly can get it, and you have a substantial chunk which are called non-radiographic. Also remember that the phenotype is distributed across the spine and the joints. You use the term axial SPA when only the spine is affected. You get buttock pain, you get neck pain, and in psoriatic arthritis, neck pain may be much more important than lower back pain. Patients may have more of neck pain, less of low back pain, and you may have involvement of the root joints. Root joints are the hips or the shoulders. Some people would have, along with the spine, peripheral joints, and I showed you examples, large joint involvement, polyarticular disease, asymmetrical involvement, lower limb involvement. And then you have some who have only peripheral joint disease and the spinal involvement may be minimal. So you could have axial SPA, you could have purely peripheral SPA, or you can have a mixture of axial and peripheral symptoms. And when you talk of predominant peripheral SPA, that happens with psoriasis. Spinal involvement may be minimal. That happens with reactive arthritis when the patient comes with explosive onset of lower limb joint involvement and there is virtually no spinal involvement in these patients, particularly at the beginning of disease. And you have criteria available for axial SPA, peripheral SPA, and the ASAS website gives you a wealth of information, but it's not my brief to go into the details of this. And I would like to end by recapitulating some important messages. Spondarthritides refers to a group of inflammatory arthritides where spinal involvement is characteristic. Should you have joint involvement that is polyarticular in nature, the spectrum ranges from non-radiographic SPA through to florid and SPON. Delay in diagnosis is common and you need to have a high index of suspicion. So whenever you have a young patient presenting to you with inflammatory back pain, don't be obsessed about disc. You need to think of conditions other than prolapse intervertebral disc. Doctor awareness holds the key to early diagnosis. Remember, women and children and even the elderly are not exempt from AS. As a thumb rule, age below 40, but you could have the first time onset at 60 also, late onset SPA. MRI facilitates detection of bone marrow edema, but don't be trigger happy. Be parsimonious with your investigations. Only when your history is suggestive of inflammatory back pain, then order a MR. And when you order a MR of the back, one of the common mistakes is to order a MR of the lumbosacral spine. If you sweep 6 inches below, you will get the sacroiliac joint. So always screen for sacroiliac joints, and MRI permits detection of sacroiliitis, which may not have become evident on X-rays. That's what I have to say in my introductory concept lecture. Thank you very much. And I would like to thank Professor Goyal for inviting me to speak at this lecture. Over to you, Ashish.
Thank you, sir. Thank you for the introduction and thank you for agreeing to join us for this class today. And I understand that you have a clinic coming up at 9 and would have to leave. But once again, thank you. Thank you very much.
All right, thanks.